One is actually, we are sitting with my mentor who trained me in interventional cardiology in 2001. And after that, only I became an interventional cardiologist. So, this is a chance that he is also with us as a course director. Along with him, and he is actually, you should understand that Dr. Sheiban has written the state of art article of LMCA intervention in Jack earlier. And everybody knows Dr. Sheiban as an aggressive interventional cardiologist. More than that, he is an excellent human being, and you cannot see such a human being in your life again. And Dr. Chen, you will be knowing that Chen is actually known for his DK crush techniques, and we are lucky that he is now everybody follows to do the DK crush technique in left main bifurcation intervention. He is also a course director. He will be joining because of his some tight schedule in the cath lab. He'll join within 20 minutes. And we have Dr. Ashok Sheth. Actually, Ashok Sheth actually messed up with the date, and he thought it is on 22nd, and he just called me and told that some real matter with his father, and so he's just missing out. Samir is down with flu and fever. He is willing to join, but only thing he cannot give a talk because of the fever. He did not tell the cause. Anyway, we will start with the program. Dr. Sheiban will be giving the first talk. He'll be going on and giving the talks on the indications and strategies of distal left main PCI. This is the first talk by him, and that will be, you can have a discussion after that, and then we will go to the next. Sir, please, sir.
Well, first of all, actually, I am really very happy to be part of this webinar. I think because of my relationship with Prathap, of course, which is a very old one. And I'm going to have my presentation on indication strategy in distal left main. I am trying to summarize what we have today. So we all know that there are different scenarios in distal left main disease, and this also make it different from patient to another. But also we have some criteria to define what is complex bifurcation or complex procedure, I would say, depending on anatomical factors, which include distal left main or left main disease itself, bifurcation, multivascular disease, and so on. Then clinical factors like comorbidities like diabetes, acute coronary syndromes, cardiogenic shock, renal dysfunction, impaired left ventricular function, and so on. And finally, also operator experience, both in surgery and interventions. I think it is very important as well. Then we have, on the other side, the patient risk profile that we have learned to assess more and more precisely, starting from an anatomical score, which is syntax score, then functional syntax score, adding the functional evaluation to the conventional anatomical syntax score, and then residual score, global score. And what we are using now more and more is syntax 2 score, which is including 12 angiographic variables, as you can see here, which is based on anatomy. But besides these, we have 6 variables, clinical variables, which add more precise evaluation of the risk of patient. That means this is what we have had before, low and intermediate high risk accordingly to the anatomy and the extension of disease, and now adding the clinical variables, then this gives us the possibility to calculate exactly, or let's say quite exactly, the mortality at 4 years for both intervention or surgery accordingly to the characteristic of patient. So this is very important because a first step in any intervention is that a good procedure starts from a good and appropriate indication. So if we follow these criteria, we are sure that we are choosing what is good for our patient. So if we now start from location of lesion, speaking about left main, we know that ostial and shaft lesion on distal left main, there is no discussion. First option is PCI based. It is doing even better than surgery in this patient. But if this will be localized only in left main and not associated with multi-vessel disease. So careful, and even in this seems to be very simple procedure, careful and precise stent sizing and deployment is very important. We should be sure that we are covering the ostium, otherwise the patient will be coming back with restenosis. Now coming to distal left main, it is still a challenging procedure. And the main issue is that technical issue is to keep it simple as possible, to plan the procedure accordingly to complexity, particularly if it involved difficult bifurcation. Intravascular imaging guidance is recommended and highly recommended, and more becoming recommended. And lesion preparation, stenting, and optimization, all these variables also are very important in and impacting the outcome, the clinical outcome. Now, how to define the complexity? Well, I think regarding the bifurcation, distal bifurcation, which is the main problem in distal left main interventions, we have for the first time a study trying to define what is simple and what was complex bifurcation, to select accordingly as the appropriate strategy, defining exactly the characteristics and the severity of disease on both main vessel and side branch. And you see that this what was reported by definition 1 study. I will not go in criteria, this can be discussed, but according to this definition study, now you see that if we are speaking about simple bifurcation, then provisional stenting absolutely is the first option, and it will give significantly better results as compared to 2 stents. But if we are speaking about complex bifurcation, it is not like this, because then dual stent strategy in bifurcation will be doing much better than single in complex bifurcation. That means significantly better the dual stenting versus provisional. The anatomy complexity, of course, you can evaluate also, just like in these examples. I'm sure that anybody will think that this lesion on circumflex can be fixed only with balloon. Then I think this, of course, right away will be planned for dual stenting. Same for this patient. Same also for this diffuse disease. So the lesion, in these cases, I think lesion preparation is critical, as well as the procedure must be completed every time you are doing 2 stents technique by kissing balloon inflation and proximal optimization every time. That means to complete stent expansion and scaffolding will be associated with improved clinical outcome. This is a very recent study from Park Group in Korea. We adapting the inspection, predilatation, stenting, and post-dilatation, that the IPSP, which is to do IVUS before, to prepare your lesion good by predilatation, debulking, whatever, then stenting, then post-dilatation to optimize. And if you are doing this, then this will be translated in much better outcome, as you can see here, in significantly better outcome in these patients. And this should be followed particularly in distal left main, because all we know that distal left main is absolutely prognostic vessel, prognostic side for the patient, very important. So just to show you, this is very severe calcification seen also on angio. And I think all you will agree with me that if this will not be guided, or if this will be debulking and guided by IVUS, then the result will not be that much good as if it's not you are not doing all these things. And we have a lot of data showing that intravascular imaging, particularly more with IVUS than OCT till now, will improve the outcome in terms of less death, less myocardial infarction, less stent thrombosis. And there is also a consensus from experts about how to use it in bifurcation as well as OCT the same. And for lesion preparation, I think this will be another discussed in a section of this webinars next week, I think, about the calcified lesion. I think when we are inspecting by intravascular imaging, we know how much calcium, we know how much debulking it needs, which kind of debulking is needed, and we have all these devices which can help us in having a good outcome. That means good expansion and good opposition of the stent in distal left main, even in calcified lesion. Now about strategies, we know that we have simple bifurcation and provisional stenting. If the lesion is stenting, that means if the patient is feasible for provisional stenting, otherwise complex stenting, and we have different approaches here. And I think we will have more data on advancing in decay crash stenting in the next presentation by my friend Chen. And we have all the other all other approaches like mini crash, T stenting, modified T, tap, reverse tap, culotte, mini culotte, and so on. All are what is used today in clinical practice. I would say that mostly in most of patients, that means 70 to 80% provisional stenting is possible. And in the two crash, in two stent technique, decay crash is becoming more and more used. And culotte as well, the modern culotte, not the conventional culotte described many years back. And of course, the operator experience in practicing or mastering a particular optimized double stenting technique is probably more relevant than the technique selection itself. So every time you are doing something, do it step by step, try to do your best every step. Now, if we look on comparison between all these strategies, we can see that there is some difference as compared to provisional stenting. Decay crash is competing with provisional stenting in terms of less death. Culotte, no, but tap, you see, it's more as well as in terms of stent thrombosis. Tap again is more. In target lesion revascularization, you see that tap is not the ideal two stent technique to use. And again, here is coming out from this meta-analysis that lesion length on side branch is very important. When it is less than 10 millimeters, that's it is a simple bifurcation, then there is no difference between one stent and two, but two stents are more appropriate when lesion length on side branch is more than 10 millimeters. And this is, I think, important. Again, other meta-analysis, recent meta-analysis showing that tap, again, is not the best technique to use, even if it's simple, but it's associated with more target lesion revascularization, more stenosis, and most importantly, stent thrombosis. And this is, again, another meta-analysis showing that if we look on scoring, taken the ranking system going from one best treatment to 7, you see that tap is associated with 6 or 7 or 4 in all singular MACE points. So I think this should be taken in consideration also when you are selecting a procedure. Now, if we consider the possibility in this patient to use mechanical support, and particularly in hemodynamic unstable patient or with poor left ventricular function, and we all know that we have the devices to do it. We should look on clinical data and guidelines also in selecting the appropriate strategy for each patient. And I think we all know these all these meta-analyses, randomized trials, and the consensus on this trial that stroke is still a bit higher in surgery. Target lesion revascularization in PCI is higher than surgery. Outcomes with this are comparable if we have patients with less diffuse disease on coronaries, and CABG is still superior in patients with multivessel disease. And this is coming from also syntax trial at 5 years, and you see that the indications, particularly in association left main with multivessel disease, should not be for the interventionist, but it will be doing much better with the surgeon. And this is also coming was the indication from European Society guidelines for myocardial revascularization. And you can see when you have more diffuse disease, then results with PCI will not be competitive with surgery. While when you have just focal lesions, that means score less or low score, syntax score, then we are at the same level of surgery. And more recently, that means after Excel and Nobel trials, which have not changed that much, but I think now we have, I'll go more rapidly for time, just to show you also at 10 years, we're still having the same conclusion as we have seen before. Importantly, I think this, what is coming from Excel sub-study regarding repeat revascularization, which is associated with high mortality in whether the patient is undergoing surgery or PCI. So target lesion revascularization, if it is repeated, is impacting mortality, and that this can explain why patients with extensive coronary disease will have more target lesion revascularization, then will have more mortality as compared to surgery. And this is also from syntax trial, again coming particularly for 3 vessel disease. You see that there is an advantage of surgery as compared to angioplasty in terms of when it is associated with 3 vessel disease. But if it is isolated, that means only left main, then there is no that much difference even in mortality. And again, you can see exactly here what I'm saying, that when you have high syntax score associated with distal left main disease, then mortality will be higher, of course, in PCI. And this also was confirmed by 10 years outcome pre-compact trial. You see that when syntax score low or intermediate, then CABG is equivalent to PCI, while high syntax score will make more competitive surgery as compared to angioplasty in terms of mortality higher in PCI, as well as serious event and revascularization, of course. All these things will be better with surgery. Then high syntax score definitely should be a surgical choice. Again, confirming the same data coming also from other meta-analysis studies, confirming that death is associated, is higher, is a predictor of mortality after angioplasty if it is lower than 30%, and age as well, death and myocardial infarction, adding also the incomplete revascularization as well as the renal insufficiency. Then operator experience, I think it is very important. So as you can see here in this study, as well as we should consider also what is the patient preference. And you can see here that if we look on what is coming from this study, whether it is with a higher educational level or not, you will see that the choice of patient regarding PCI versus angioplasty or medical therapy, with 50% of these patients, independently of education level, they will choose angioplasty rather than the alternative. So I think this should be taken in consideration also when we are selecting our patient. Heart team discussion, I think this is already accepted globally. That means heart team should be there, should be compounded in every reality, in every facility, doing both angioplasty and surgery. And we should follow strictly the guidelines which have been changed in favor of angioplasty during the last 3 or 4 years. And you see that from 18, we have equivalence in left main angioplasty in low syntax score. We have now class 2A in those with intermediate, but again, high syntax score, I think, should still a surgical patient. I would conclude that saying that different scenarios, of course, but the key points in strategy selection is patient's comorbidities. That means syntax 2 score, how many stents needed to achieve complete revascularization in the patient, I think is another key point. Heart team discussion and patient-informed consent and preference. And regarding PCA, if PCA will be the strategy chose, good experience, intravascular imaging for procedural planning and optimization, and keep it as simple as possible. Thank you very much for your attention.
Sir, it was a wonderful talk, and you just covered everything. Actually, Dr. C.G. Bahule, Professor C.G. Bahule also joined for the meeting. He is also my teacher. Sir, actually, you can have some discussion, sir, please.
Okay.
Thank you, Prathap, and thank you for getting me involved in this wonderful program. And very nice to see Dr. Sheiban after a little bit of gap. And nice to hear you also. Excellent talk. I think you have covered extensively very well with a short of a time. See, 1 or 2 questions I would like to get answered from you is one. You know, we have the EBC left main now published, discussed, and presented. We have the definition 2 trial also published and presented, and people were looking forward to what is winning. Is it provisional strategy or 2-stent strategy of different techniques? And now definition 2, you have touched upon nicely of defining what is complex left main bifurcation and how decay crush has won over the rest of the techniques. But EBC after that has come forward and said that, look, 2-stent is not probably the way forward. You have to start with provisional. And they have coined a new terminology known as layered provision. Start every case with provisional, and you decide at what stage you diverge into a 2-stent strategy. That's one aspect why this difference I would like to get from you.
Well, actually, I think I have been in EBC meeting just last week. Actually, we should admit that EBC main, it is including complete different population as compared to decay crush versus provisional stenting. That means all patients included in EBC main are simple bifurcation lesions. And it's under this point of view, under this light, I think we do not have any new thing from this study, because we know that just from before many other studies have been showing that in simple bifurcation, when you have lesion length on side branch less than 10 millimeters, then provisional stenting is the choice, the first choice. But if we have longer lesion on side branch, that means more than 10 millimeters, and of course this will make it more difficult to be fixed by only balloon, as we all know, and this making also the lesion more complex. Then I think planning for 2-stent strategy in patient with complex bifurcation defined as definition criteria, I think can give more possibility of larger benefit on outcome. That's because if you are starting every time with provisional stenting, then you are shifting to 2-stent, then you have to go for reverse culotte or tap. And I have shown you now that this is not the ideal approach in two-stent technique. So I think it's much better to know to plan your procedure according to the complexity of lesion just before starting your procedure. If it is upfront for dual stenting or upfront for dual stenting, with whatever you want, the technique or strategy where you are mastering with, that means you are confident with, do it step by step and try to optimize your work. And this will be associated with good outcome as well.
I certainly appreciate and then join with your idea that, in a given case, based on the anatomy which you study and then choose of upfront two strategy, maybe a practical way to go forward, that
Yes.
rather than simply start with provisional and getting into the two-stent technique.
Actually,
one another question is from your point of view of discussion, where will you place the patient characteristic of diabetes in choosing the types of revascularization, whether it is PCI or surgery? What is your approach?
Actually, I jumped on particular, but there also was a confrontation between diabetic and non-diabetic. Of course, diabetes is adding more risk for the patient, and actually seems to be surgery to be the first choice if we are comparing outcome in versus intervention. But I think it depends also on the extension of disease in diabetic. That means you should look on angio, because we have many diabetic patients that have focal lesion on 3 vessels, and this will be doing good also with angioplasty. But if we have extensive disease, 3 vessel disease, then of course this might add more mortality if he diabetic as compared to surgery. So I think diabetes is a very good point. Coming back to the first discussion before, during EBC, Adira Banning from London presented sub-study on EBC main, and he showed that if he will locate the patient accordingly to definition study criteria, then also EB main complex lesion, 2 stents will do better than 1 stent. So this was really surprising me. But actually, I hope that they will publish this, because this will be clarifying everything. And I think we should come to a global agreement about definition. What is simple, what's complex? And then we have resolved the problem.
Sir, one question, sir. In
Yes.
provisional stenting, do you keep open the stent cut or not?
Well, I think in this lift name particularly, I think it is important at least to be sure that you have access to what you have considered side branch, because actually it's a main vessel. In the future, you might need to go to do something on that vessel because of progression of disease. So what I'm doing normally in this lift main, I will go with the wire. I will retrieve the jail wire. I'll rewire the circ and go take a balloon, go. If I don't have any friction, I'll not do anything. If the circumflex, for example, in this case, is not compromised, having good flow, no pinching. So it's not needed to open anything because you have complete free access. If you have some strut still lying that, you don't go with a balloon, I think, yeah, you have to go to open and to open the strut and be sure that everything is good. However, I think you should be very careful about what you are doing, because if you are deforming the stent, then you have to complete with kissing and pot proximally again, repot again. So I think this is step by step you should do everywhere, every work you are doing. But again, regarding the opening of the strut, if needed, I will do it. If not needed, I'll not do it.
Madhu, any comments?
Yes, Dr. Sheiban, excellent talk. I just have a question. Like you, in your trials, you found that the tap was the worst of the lot. but the EBC guidelines, they say they've taken off the crush and the mini crush, and they've put more focus on the T and tap. So how do you see that?
Actually, if you look on the first meta-analysis I show, there are two or three names from European Bifurcation Club. So actually, really, I don't understand why they are insisting so much for this. And they even failed to show that even in simple bifurcation, provisional stenting is not doing better than 2 stents. So why I have to limit why I have to limit the operator experience? With other, just to use only tap or reverse culotte. Personally, I don't like to leave anything protruding in main vessel. That means whether it is coming by a crush, reverse crush, or by tap or by culotte. If I will start with these techniques, I'll start from side branch and keep main vessel, what I consider main vessel, free of any protrusion, because this is always associated with higher thrombosis. So this should be kept in mind. Actually, I do not have any answer, but I think that about your question, but I think this is coming because of maybe conflict of interest, I would say, because somebody or writing these consensus having also the first author of TAP, for example. So this could be. I'd like to
No comments, sir, please.
Yeah.
Chirag, any comment? If there is, Chirag?
Yeah, so just wanted to have one small question, like how would you approach a patient who has acute coronary syndrome and thrombotic occlusions of left main? How would you approach distal left main lesions or left main occlusion?
Acute thrombosis.
Yeah.
That means he is coming for ACS?
Yeah. Yes.
Well, I would say I will do as soon as possible. I'll recanalize. That means if even with aspiration, but it depends on the stability of patient, what to do. If the patient will give you time to do something more than stenting, I'll start with something more than stenting. That means I'll clean up what I can to take out some thrombus before stenting. To be aware about shifting of thrombus during stenting from one side to another. So all these things should be considered. However, it depends on how emergency you are. That means if the patient is surviving, if you are doing some maneuver also on the patient and you are working in the meantime. So it depends. But I would prefer, of course, having, if the patient, if the condition, clinical condition will permits you to do it, to go with aspiration before, to remove some thrombus before you are doing any other thing.
Sir, Dr. Chen's so far not joined, so we will, can I go ahead with my talk?
Oh, yes, of course. Of course. I think we can go ahead because he is in connection with TCT now and he will be coming soon. He told me, he sent me a message before.
Okay, sir. Okay. Some of the people would have seen this case. Actually, I'm just presenting this case. It is an LMCA interventional case. Basically, a 31-year-old female patient had an acute coronary syndrome, unstable angina, post-cabbage patient, and off-pump in 2012. That was a surgery done, Lima to LED. Cabbage done for the LMCA disease of 95%. Patient had a treadmill positivity now, with an echo shows an anti-wall is hypokinetic, ejection fraction of 50%. And patient was admitted for a angiogram with ad hoc angioplasty. But the interesting point is patient is on tracheostomy arthritis and anemia. There is no history of diabetes, hypertension, or family history. This is the angiogram. Angiogram shows a totally occluded LMCA. You can see the cannulation also was so difficult. But the right coronary is totally filling everything to the left system, and the Lima 2 LED is occluded. And the patient actually came with a refractory angina, and TMD is strongly positive. It is 7 years post-cabbage. So I started this case with a caravel into the, I just took only one catheter that time. I have taken 2 sheath, but caravel with a filter FC wire. I decided to take the wire inside. You can see that I have chosen a septal collateral. It was looking very straight to the lady. You can see that wire is actually bending towards. I already selected the septal channel before that. It was a bent wire. It's a bending inside. The wire goes up. This is actually the lady, and it went inside. So the wire went inside along with the caravel, and the wire easily crossed into the left system. But the point is actually there is no coronary, there is no catheter to receive the retrograde collection. So it was difficult to cannulate. So I tried cannulating the left system. I took a 7 French ABU catheter. I failed to cannulate. I changed the wire from filter FC to cyan black. I thought cyan black will take an easy curve and go up. Not possible. Then this is a 7 French catheter EBU. It is not at all sitting in a line. Then I changed the catheter to JL catheter. I thought JL may take it, but the wire is outside. JL actually not at all able. But I could even take my caravel outside the coronary. Then the next step was I tried a snaring. But the major problem with the snaring actually, because of the Takayasu, there are a lot of problems, and snaring also cannot take in a very nice way. I tried snaring. I failed the snaring also here. Once the snaring also failed, what I thought, I may try antegrade wire. Nothing is seen, but I tried an antegrade wire, that is a filter XTR, but I could not take the wire inside. Then what I tried is actually, I tried a UB3 wire instead of the third wire from retrograde. I tried a UB3 because UB3 actually can be a tough wire. I thought I can take through the snare, but UB3 also could not help me. Then I thought probably the angle of the septal entry was difficult. So I decided to take another septal entry. So the septal, the last septal was there, it was taking a long path. So I thought I'll be taking a different septal artery. This septal actually taken inside. You can see that septal artery going up. This wire is actually going easily up. So this is a very much closer to the LMCA system. So I thought I'll be taking this septal. So tried another septal channel. Then I tried. Again, the wire went easily inside. Once the wire went easily inside, this is actually the second septal channel. Then I tried, not possible. And it is also not cannulating. So it is not at all able to enter inside. So then this time what I was seeing that actually the antegrade injection showing a faint flow, the antegrade. Maybe because of my microcatheter gone 2-3 times outside. So it created a faint channel. So I thought I will try in another antegrade projection, that is an epicranial projection, so that my catheter will sit in a line. And so I tried an antegrade entry with a filter FC wire. This is the wire filter FC, keeping the retrograde caravel. I thought I will take an antegrade wire. So this wire is actually, you can see that the wire easily entered inside, but the wire actually, once it is entered inside, this, you can see this wire coming out. So by keeping the caravel there, I tried this wire to enter inside. This is the wire entry. By keeping the wire, luckily the wire entered inside. So once the wire entered, the wire did not go to the LED, but wherever it gone, I was so happy the wire gone into the OM vessel. So you can see the wire entered into the OM. Once the wire entered into the OM, I thought by keeping this wire alone will be dangerous. So keeping that wire, I took one more wire. I took one more wire that went into the circumflex artery. So we have 2 wires, one into the OM, one into the circumflex artery. By that, I took a 2.58 Maverick balloon into the circumflex. So I dilated, I opened up the LMCA. Once I opened up the LMCA, there is a space created. So now I decided I will take an XTR wire into the LAD. This is actually the XTR wire because I have one wire into the circumflex artery. So I took another wire into the XTR because I know that this small channel, the XTR will easily go. So this is an XTR wire. I thought an XTR wire by keeping the caravel, you can see the caravel is sitting there. With the help of the caravel and the wire into the circumflex artery, I was able to take an XTR wire. This is an XTR wire. If you watch carefully, you can see that. That wire enters. Once the wire enters, so I have a wire into the LAD, I have a wire into the OM. So I decided to, reticulate system is totally removed. I don't want that system there. I just took a 3 into 12 millimeter balloon, dilated. Then once I dilated, I opened up the vessel. We can see everything is opened up. We have another wire. So I took an IVUS there. So I just wanted to understand that how is the anatomy of this part. So this is the IVUS run. You can see a plaque in the ostial LAD. That the plaque is extending from the LMCA to the ostial. This is actually the distal LAD part, looking very nice. You can see a plaque there. There is no big dissection in the part. So I just wanted to know that whether I am in the true lumen totally or not. So that is the first and foremost thing in IVUS measurement in CTO section. So I just see that there is a plaque there, but this is the circumflex artery coming up. This is the LMCA. LMCA is, you can see the LMCA. This part is actually, probably I don't know, but I was thinking it is because of the Takayasu disease. So we saw the measurement. It is actually 12 plus 7, 9 millimeters, 19 millimeters is there. There is a plaque up to the ostium of the LAD. That is important because I should have a crossover stent from LMCA to LAD. So I have seen a 9.5 millimeters of LMCA and another 12 millimeters into the LAD. So there is a 12 plus 9, 20 millimeters. The distal LMCA, I can see the measurement is only 2.96. And the LAD was looking like a 3.24. So the distal LAD is only 2.9 measurement. Maybe it is actually atretic in the LMCA part. So the distal reference was 3.24. So any questions? So just I did a flextome to improve the size of the LMCA because I know that there is a lot of plaque inside. So I took a 3 into 10 flextome and dilated. So this is, I thought after that I will do one more IVUS to understand. So I can see that there is a lot of vasa vasorum there. The actual dilated vasa vasorum. You can see the distal vessel, and we understood the proximal LMCA looked like a 3.25 vessel. So we took a 3.5 resolute onyx stent extending from the LMCA, that is a 26. We thought 12 plus 9 is 21. So we took a 26 millimeter stent, extending it to the LAD and positioning the stent in various angles because the ostium is not very well clearly seen. So we positioned to understand this will be the ideal position. In various angles we position and then dilated, taken the stent back to for the flaring. So after that, we did one more IVUS to understand whether the stent is opened up or not. This is the final IVUS for the patient. You can see the IVUS run. Not the same IVUS. So this is IVUS run. We got a 3.36 display. This is the standard part. Circumflex coming up, the branch. There is some under expansion in the proximal part of the LMCA, but the ostial part is well opened up. Probably 1 or 2 stents struts outside. Let us see. So it is 2 struts outside and is well covered. So we got a 3.36 millimeter square, and we got an 8.28 millimeter square is the ostial LAD, and we got an LMCA part of 10.76. So we were really happy, but there is some under expansion distal edge. So we thought we will do one more dilatation to see, and there is a 4 into 8 millimeter maverick balloon dilated only in the LMCA part and created the result. So we were happy. This is the final result of the case. But the story does not stop here. The patient to the PCI to the LMCA CTO was done on January 2021. A patient had a COVID vaccination on 25, that is in the month of May, and patient had an acute NSTEMI on 25th, exactly after 5 days of vaccination. Maybe it is a correlation, we don't know, but the normal LV function with an ejection fraction of 60%. So we decided to do an angiogram that was surprisingly was in a very, very bad result exactly after 5 months. This is the story. The patient had a complete occlusion of the, almost like a complete occlusion of the LMCA. We have taken in different angle to see. We have to understand that this is the angiogram to show the subclavian artery because of the Takayasu arthritis. You can see it is a totally arthritic Takayasu. Basically, the vertebral artery is having a problem. The lemma is totally arthritic. Nothing is there. So you have no other choice left out. So we have taken the patient again to understand that and told that the patient will have a recurrence again because of the Takayasu. So what we did is we have taken a 7 French GBU catheter, kept the catheter in the right position, and I manipulated the wire from outside. And I tried to rewire the wire exactly from the ostium inside. You can see that wiring was it is a little tough job, but I kept the wire little away and the catheter away. And you can see the wire is going exactly in the middle part and then went inside. Once the wire is entered inside, we were very happy. We are in the vessel. You can see the wire gone inside. Once the wire gone inside, then this is actually a Philreps wire. We took one more wire into the circumflex artery because it is important to see that the wire should go to the circumflex as well as to the LAD. The wire gone. This is important in wiring properly. So we have taken the wire in different angle. You can see the wire will go. I've taken some time to rewire these things because I have made a bend inside so that the wire should go into the LAD first, and then I wanted to come back and then do it. I have taken the wire back. Again, I have taken the wire, and when the wire gone inside, then I understood I am in the vessel. From there, I just made a bend into the circumflex artery. You can see that wire went. I wanted to make it sure that I am in the circumflex artery. The wire went inside. The 2 Philreps wire, one into the LAD, one into the circumflex. After that, I did a balloon dilatation of 2.5. So because this time I just wanted to understand what is anatomy by doing a OCT. We did a 2.75 into 12 millimeter balloon across the diagonal, across the circumflex artery. Then what I thought is we have a wire inside, and we decided to take it. This is an OCT imaging of the patient to understand what is the problem. So this is a pre-run OCT LAD. You can see that there is a lot of neointimal hyperplasia. We can tell anything. It is actually an IH. It is not atherosclerotic. It is actually called neointimal hyperplasia, because we can see that there is a tightest part in the ostial part of the LAD, almost at the LMCA distal and the ostial LAD, which is actually very, very tight. You can see there is only 1.93 millimeter square is the tightest part, and is very tight in the osteoproximal part of the LAD as well as the LMCA distal. You can see there is total lot of plaque inside, which is this plaque is actually created by some dissection created by 2.75 millimeter balloon. Why I did this one? To take the OCT catheter inside. So then I did a flextome again here because it is already, there is a lot of neointimal hyperplasia. I took a 3 into 10 because the strength is actually 3.510 and which we dilated. This is the, after the flextome, this is one. So we did a bifurcation run to understand that the bifurcation opening is good or not. You can see that this is the bifurcation opening. Opening is very good here. So that circumflex opening is very good. So I decided that nothing to be done to the circumflex at all. So what we did is actually, we took a magic touch. People will accept or not. I decided not to put a stent again. I decided to take a 4x20 magic touch because the stent was 3.5x26. So I took a 4x20 magic touch with a 2.75x12 Maverick balloon into the circumflex, which I did not dilate high pressure. I just went only 4 atmosphere and then kept the 4 atmosphere, and then 4.5x10 is actually, after this, we did a port of 4.5 balloon. This is the final shot created after the final angiogram. And then we did an OCT run also. This is the final OCT run. We got an area of actually the MSA and the distal LMCA actually. Distal LAD was 6.76 and the proximal part was 9.7, which was almost a similar MSA we got before the angioplasty also. So we got an area of 9.94 and we got a reasonably good opening of the vessel. But we just did a magic touch. We did not do a stenting in this case after the flextome and dilatation. So this was the final run. We can see the 3D run shows that the wire was totally going to the lumen, and we have seen an excellent opening of the stent. There is almost no stent start across the circumflex artery. So this is a reasonably good result. I really don't know. This is now only, you can see that it is 4 months now, and the patient is doing still very well, and on immunomodulators as well as on steroid. So the LMCA CTO is a rare one. It can occur in Takayasu arthritis. ISR is very common in this disease. LMCA intervention aided by the imaging procedures gives excellent long-term result. That is what we think. But what about Takayasu arthritis? We don't know. During CTO intervention, to understand the expansion, apposition, and edge dissection of the stenting can be identified by imaging. During follow-up, to understand the reason for ISR and solution for which can be identified by OCT. Thank you very much for the patient lesson, and we can have discussions.
Thank you, Prathap. This is a fantastic case. I think it is very educational, very, very complex as well. It's open for discussion.
I think, sir, in the meantime, Dr. Chen joined, right?
Yeah. Dr.
Yeah, I'm sorry.
Friend.
I'm so sorry. You know, I forgot the pre-recording of TCT session. So this morning they ordered me have to pre-record this evening. So I'm so sorry.
No problem. It was very nice. Thank you.
Yeah. You are in time. You're still in time to stay with us. No problem.
Okay, thank you. My pleasure. I think the case by Dr. Kumar is very, very interesting. It's not real in our daily practice because I did not know the patient history before. So just one question. You know, in our center, we usually need to measure to assess the inflammatory status for patient with cardiac disease, and also for patient who has the occurrence of incident recent, we prefer to send the patient to do CABG.
The patient already had undergone a bypass surgery already, and patient actually came back with a restenosis. Bypass done at the age of 24. Patient already had done a bypass surgery in the age of 24, and after 7 years, patient came back with a completely damaged lima to a lady. There is no lima now working, and the subclavian artery is also occluded. There is one more chance was the patient can have a vein graft to the LAD, or you can have a rima to LAD. Lima is already not gone, totally gone.
I see.
No chance. That is why the patient actually had a bypass surgery done at the age of 24. Patient came to me at the age of 31. After 7 years, patient came to me, and then one procedure I have done. I personally did the one procedure 3 months back. Then I did one more procedure. Now another 5 months. The total time is 8 months now. 2 procedures now.
I see. Thank you. Thank you.
Prathap, can I have a couple of questions? One, in the first time when you're wiring the retrograde channel, you change the septal, but the wire had gone the cross lesion into the aorta. So why did you have to change the septal?
That is, this question is asked actually when I present this case in CCT in presence of Dr. ABM. It's a wonderful question, but problem is actually when I had a septal channel crossing in the distal part and the wire is taken, your torqueability of the wire and the strength of the wire will be different. But when you take in a very small angle, your chance of managing the wire to get into the snaring will be easier. So you are very close to the LMCA. The second channel was actually I've taken it two septals. The one channel was little far away, so my manipulation will come down. The other one is very close to the LMCA part. So I thought by changing the septal channel, my success of entry into the snaring will be easier. So these are all my thought process. I actually tried to manipulate this wire to get into the snare, get into the catheter. Well, nearly the wire crossed in just 3-4 minutes into the LMCA. But after that, I was actually having a struggle of taking the different catheter.
Could you have taken a bigger snare or something? Because the wire is already there in the aorta. So
the problem is actually this snaring is problem in these cases. In Takayasu, the problem, your manipulation itself is a problem, because actually I'm telling in the aorta itself there is a problem. So that is actually the problem. When I discuss with many people, then aorta will have a lot of problem there. So the manipulation will be a real tough challenge.
That is what I wanted to ask you. I mean, if you will go more distally with the wire, I mean,
so wire was
pushing the wire in the aorta, more in the aorta.
I tried to pass the wire into the right brachiocephalic artery. That is the way I just usually snare it. But the wire never went there.
Okay.
Wire is not going at all. So I tried to take the wire into the right brachiocephalic artery so that I can snare easily. So this time it was not possible. So
and what about the possibility to go with a balloon over that wire already outside from the ostial of left main and to dilate retrogradely?
So actually taking that balloon through the septal channel by a balloon, you can easily take the balloon there. But when you take the balloon back, because then it will be an inflated balloon and then deflated. So it will be a bigger size balloon. So when I was under the impression it may damage the channel. So once you damage
over the wire balloon could be
it will
working.
be a possibility, sir. It is a possibility.
Yeah. If you remember the first case I did in 2003, it was with over the wire balloon.
Probably that was the first retrograde intervention in the world.
I think, it was presented on TCT the year after, and that was a very, very challenging case,
And Prathap, second time when you're wiring, because the stain was outside the aorta, it is protruding, at least a few struts were into the aorta.
The two struts outside, actually, I always, when you have an ostial tendon, you actually want...
that's fine.
That is what I was seeing. You can see that even in the ostial part of the LMCA, there will be some extravasation-like thing. Which you can
not that. No, my question is, when you're wiring the second time with the struts into the aorta, how certain are you that it's going into it? I mean, it could come, above the stain, side of the stain. How certain?
No, that is actually one way you can understand. You can actually go to 3 different angles to understand whether you are in the middle part of the stain. And I usually take a different way. When I take the wire down, usually people will tell that I take an Oaks balloon to understand. If the Oaks balloon crosses the stent, that means you are definitely inside. Otherwise, even as a new balloon is easily can be crossed through the stent strut and go inside.
And the last one, when you have the drug-eluting balloon in the stent, you had dissections in the left main. I mean, it's within the stent, but how confident are you in leaving a dissection in the left main?
Madhu, basic problem is actually in Takayasu. The principle is actually... I
understood. Actually, I'm just questioning the dissection in the left main. How confident are you in leaving it? So did you have a problem or you just...
No, I will tell you why I left it. Because then I remembered only one thing. Though George Joseph actually told me many times, during in the carotid stenting, he created a dissection by doing a cutting balloon and just leave it, so that he is telling that it will heal off. That is actually the principle of Takayasu. So I thought, let me try on that. Even if the patient is having a problem, I will just come and do any stenting, because already I opened up the vessel now.
Yeah, actually, if you have dissection without staining, I mean, contrast staining, no flow disturbances, I think you can leave it. Like the dissection A, and you can leave it, can heal very, very safely.
My question is the left main. You're always concerned. The stain is protruding out. You have a left main dissection. I mean, it healed finally, but in case there's an acute closure later on,
But
would that be a concern
this
at all?
left main having a stent before, right?
Yeah, but
already a stent before, and there was a tight disease also.
Yeah.
It was a totally occluded left main earlier.
Yeah.
The Bowlen, sir, any questions, sir?
No, I think it is a wonderful case. I have witnessed it during the last ICCK meeting. But one thing, as Dr. Sheiban asked, you could get the caravan into the aorta through the left main sometime.
I took the
You
caravan outside.
So could you have used that caravan to guide your wire up into the brachials?
That was the toughest problem, sir. Usually what I do is I snare it out and take it out easily in mini retrograde. But this
now that it has failed the snaring part.
Sir, the wire was never going out. Actually, wire was just moving around there and here, and it is never pushing, and I could not push the wire into the brachiocephalic artery. That is why I tried a different channel. Madhu asked why a different channel. I thought through a different channel I may go, but I failed there also.
Yeah, different channel is understandable because the angulation is very important when you get into the main vessel. That is true. Now, one more question. You have used a drug-coated balloon for treating this one.
Yes, sir.
As it stands today, you have placed a drug-eluting stent earlier. So, drug-eluting stent restenosis is the consensus today is better treated with another drug-eluting stent rather than a drug-coated balloon. The results are more in favor of that in general.
Correct, sir. But actually, in a patient with the Takayasu keeping one stent and then again restenosis, this is a real interesting case, sir. Actually, the
true, very true. I understand.
Follow-up will give you a lot of ideas.
Yeah.
I think when you are doing these things, you should keep under control the patient also as well. I mean, he should be coming back 2 months later, and you have to check on the patient, because I mean it's very important, particularly if it is not collateralized by right coronary artery.
I told the patient that you should be ready for an angioplasty again after 3 months, but luckily the patient now 5 months over. So we are actually happy that we are following up with this patient every month, not routine, sir.
Absolutely, it's important follow up in this patient. Absolutely.
Chirag, any comment is there? Chirag?
Yeah, so just wanted to, I mean, it's an excellent case and a rare clinical scenario, very complex one. Like what you have shown in the left main significant instant restenosis, you dilated again, I think first with a 3 millimeter flextome. And there was significant amount of neointimal hyperplasia that you had shown. And thereafter you treated with drug-eluting balloon. Since you had one very well expanded stent in C2, do you think that using a bigger size flextome would have made a better luminal gain in the first go and thereafter drug-eluting balloon? Like 3.5 or 4, even 4?
Correct, but actually the vessel size was in the first time when I was showing only 3.3, then I used a 3.5 stent. 3.3 was the size I could measure in the first time. Then I used a cutting balloon. When you use a cutting balloon, you should be 0.5 less than the nominal size. Even though I used a 0.5 in as the post dilatation at the pot in the first time. So I did not. I thought I will use only a 3 millimeter balloon, cutting balloon. I was also a little hesitant to use multiple things in this case because I'm afraid. And she is only 31 years.
Actually, the stent was very well opposed and expanded. So
yes. So I think what I thought was maybe a higher sized flextome would have made luminal gains much better at baseline, followed by drug-eluting balloon, because already we have stent in C2, so we are not worried about cutting balloon causing some complication.
No, actually it could have been done, but I decided to take a 3 into 10 because
And the second,
I think whenever you can spare overlapping stents, it's good to do.
It's good. Yeah.
Yeah.
And second question was, I think, a post-dilated further pot with a 4.5 millimeter balloon after drug-eluting balloon, right? Am I correct?
No. That was
Okay,
actually
okay.
done in the first case.
Okay, in the first case. All right.
That is again 4 into 8 only, not 4.5.
Okay,
Because the rest size was only 3.5.
Only 3.5.
When I saw some malapposition, I just went up to 4.4 into 8. And next time, since that is why I took a drug balloon 420 only, not even taken. Because I know that after drug balloon, I don't want to take any other thing.
That's right.
Right.
That's right. Yes.
Actually, we have to stop here because of time. I think we have to go for next presentation, and I think I'm sorry to stop you. It's very interesting.
No problem,
case,
sir.
and we have
Actually,
a
we
lot,
can go
a lot of
Chen
things.
for
Yeah.
his presentation.
Yeah. And I think we have to go ahead because of time, because we have
Please, sir.
yeah,
Dr. Chen can give his
Professor Chen now ready with his presentation.
Can you hear me?
Absolutely, yes. Go.
Oh, thank you. So I have nothing to disclose. So basically, so far, there are some published randomized clinical trials to compare different stenting techniques for both distal left main and non-left main bifurcated lesion. For distal left main bifurcated lesion, so far there are 3 trials, EBC main, just recently published. Our DK-3 and DK-5, these 3 studies. For non-left main bifurcated lesion, there are more randomized studies. So we are very comfortable to get our results from definition 2 and the DK-2 study. So in terms of the provisional stenting technique, all of my colleagues are agreeing with me. So provision does not mean one stent. It could be transferred to 2 stent or a 1 stent technique. So let's back to the study flowchart of DK-3 and 5. DK-3 compared to culotte with DK-3. DK-5 compared to provisional with DK-3. So both studies are designed in a very similar way. Both studies have provided 1 to 3 years of follow-up. So from our previous DK-2, DK-5, and DK-6 3 trials, we gradually recognized the importance of side branch lesion length. So the table summarizes from 702 patients who treated by provisional stenting technique. So you can see clearly over the increase of side branch lesion length from 5 to 10 millimeter to a minimal 10 millimeter. So cardiac days, target vessel mark, cardiac infarction, TLR, TLF, and stent thrombosis increased very, very significantly. So last year, Dr. GR performed a meta-analysis to provide the cutoff of side branch lesion length minimal 10 millimeter was associated with a high rate of clinical worse events. So this was a study we published in 2014 to create definition criteria from our 1,150 patients with bifurcated lesion. So this criteria from a study group had to be testified in another validation group, including 3,660 patients. So this is final definition criteria to differentiate simple and complex bifurcated lesion, particularly for distal left main bifurcated lesion. So any lesion, if it made side branch lesion length minimal 10 millimeter and baseline diameter, stenosis minimal 70% plus any 2 minor criteria, should be classified by complex bifurcated lesion. I think this is the first simple angiographic criteria to differentiate simple from complex bifurcated lesion. With the upcoming of the definition criteria, so we design our definition 2 trial. So here I appreciate Professor Sheiban very, very actively participating in this trial. So finally, 660 patients with real complex coronary bifurcated lesion according to definition criteria, were randomized into provisional group and a two-stent group. So the primary endpoint was 1 year tight lesion failure. This study was conducted at 49 international centers. At 1 year follow-up, so provisional stenting technique had high rates of TLR, tight vessel cutting infarction, leading to subsequent very high rate of TLF at 1 year follow-up. In two-stent group, more than 80% of procedure were DK quash technique. So here we are very, very comfortable to say DK quash is superior to provisional stenting technique for real complex bifurcation lesion. Following the previous result showing high rate of per-procedure myocardial infarction of the provisional stenting technique. So the last year we published our another OCT bifurcation trial. So from 400 patients with a Medina 111 and 011 true coronary bifurcation lesion of the provisional stenting technique, all the patients with long side branch lesion lengths were divided into patient with and without vulnerable plaques in the main vessel. So actually, this is a very important study to answer why there was a high rate of PMI of the provisional for patient with long side branch lesions. So from the figure, you can see very high rate of tight vessel myocardial infarction among patients with long side branch lesion lengths simultaneously with vulnerable plaques in the main vessel, but no difference in terms of the cardiac death and target lesion revascularization. So this study was published in CCI. So nextly, with the given knowledge of high rate of PMI after provisional stenting for complex bifurcation lesion, but there was very, very limited data showing the correlation of PMI with mortality after bifurcation stenting. This is our new study, recently just published in CCI2. So from 1,825 patients with Medina 111 or 01 bifurcation lesion from our previously 4 randomized study. So finally, 1,300 patients were included in the final analysis. So for this paper, Professor Sheiban was the first author. So I acknowledge Professor Sheiban much more. Finally, there were 56 patients who had per-procedure myocardial infarction. So this figure shows the distribution of the PMI according to 5 different definitions. So in general, first UDMI or ischemia definition has similar prevalence of PMI after bifurcation stenting. But for syntax, Sky, and Excel 3 definition have very similar rate of PMI. Again, a different definition showed a different correlation, different rate of all-cause death and cardiac death for patients with PMI at long-term clinical follow-up. I think this table is very important. For our 1,300 patients, so the median follow-up duration was 3.5 years. So according to the adjusted analysis, there was no difference between PMI and any cause death at a 30-day and 1 year follow-up. But since the 1 year follow-up until to the end of the study, so syntax criteria, Sky definition, and Excel definition define the PMI have very, very strong correlation with any death during follow-up. Again, from our large database, we tried to identify one simple biomarker cutoff, CKMB value, to identify the correlation with mortality. So from table, you can see for patients with CKMB minimal 5 times increase, so very high rate of mortality during follow-up. I think this is very simple, very easy to guide our intervention cardiologists to pay much more attention to patients with significantly increased CKMB. So again, in the next remaining slide, I tried to briefly summarize the comparison of DK quality 5 with EBC main. As I stated, there are only 3 trials, EBC main, DK quality 3, and DK quality 5 trial, compared to different staining technique for distal left main bifurcation lesion. Because DK quality 3 compared to DK quality with color staining technique. So here I concentrated on the comparison of EBC main and DK quality 5 trial. So in general, from the table, you can see a more simple lesion included in EBC main. For example, syntax score less than 32, MI older than 72 hours, no CTO lesion. Particularly, TAP, culotte, or DK quash were allowed in the used in the two-stent group, but finally culotte was used in 53%, TAP 33%, DK quash only 5%. But the primary endpoint was any cause death, myocardial infarction according to SCAI definition, as I introduced previously. SCAI definition provide relatively high rate of PMI of the PCI. But both studies are designed as superiority design. So again, in EBC main, the assumption was the primary endpoint was 25% in the two-stent group. But in our DK quality 5, the primary endpoint at 1 year was only 7% in DK quality group. Both studies had very similar rate of primary endpoint in the provisional group. Finally, syntax score, the mean value of syntax score in EBC main was 23, significantly lower than 31 in our DK quality 5 study. Very interestingly, the side branch lesion length was only around 7 mm in EBC main. But from the study protocol of EBC main, though, the one inclusion criteria for side branch lesion length was longer than 8 mm by visual estimation. So this is the first point of validation of the PI against the study protocol. The side branch lesion length was 16 mm in our DK quality 5 study. Particularly, complex bifurcation lesion was not reported in EBC main, but it was seen in 31.5% in our DK quality 5 study. So immediately after this procedure, so the crossover rate from provisional to two-stent was 22 in EBC main, very lower than 41% in our DK quality 5 because of the relatively simple lesion, more simple lesion in EBC main. Average use was similar in two studies. At 1 year follow-up, so the primary endpoint of the provisional staining technique was 14.7 in EBC main, similar to 10.7% in our DK quality 5, but very high rates, relatively high rates of primary endpoint of the two-stent in EBC main compared to DK quality 5 study. So actually, in terms of the individual items of secondary endpoint, they all are similar between provisional and two-stent in EBC main. But in our DK quality 5, DK quality show very low rate of tidal vessel myocardial infarction and also tidal lesion, revascularization. Because most lesion in our DK quality 5 study were classified as complex lesion. So for some patients, after provisional staining technique and the required additional side stent, they saw very high rate of stent thrombosis at a 1 year follow-up in provisional group. So in general, we have many criticisms on EBC main trial because this was EBC main was initially a superiority study, but finally it had all neutral results. So for such kind of field trial, we could not see a treatment A non-inferior to treatment B. Also, because of the very wide gap in terms of the assumption of primary endpoint in two-stent and provisional group, which will induce very high rates of bias and type 2 errors. Also, I think from the study, from the quality control of EBCMA, only 85% of patients had appropriate cardiac enzyme measurements, which may implication for the assessment of periprocedural myocardial infarction, a component of the primary endpoint. Also, if from the paper of EBCMA, I think it will be very dangerous to our intervention cardiologists, for very complex distal left main bifurcation lesion. They always encourage our colleagues to stepwise provisional standing technique, replacing of systematic two-stent technique. Here, this is the last slide to show how to decay quality. I think all friends are very familiar with this technique. I don't want to spend much more time and leave more issues to be discussed during our discussion. Thank you very much. Thanks for your attention.
Thank you, Xiaolian. I think we have discussed before you were joining us about EB. But anyway, I think there are much more questions raising up. Please.
Dr. Chen, actually, according to you, all stenting techniques in LM bifurcation, the decay is better than anything, right?
Yeah, actually, I think for simple bifurcation lesions, so far we have no data to show this superiority of decay to provisional. But for complex bifurcation lesion, decay is a king.
So simple bifurcation, you can even try provisional rather than decay, right?
Yeah, right. In my case level, I think we have the similar data to show the prevalence of simple bifurcation lesion. So it accounts about 70 to 75%. So for the remaining 20 to 25% complex bifurcation lesion, we have to decide when and how to do two-stent technique.
According to you, the complex bifurcation side branch lesion is 7 millimeters or 10 millimeters?
10 millimeters.
10 millimeters.
Xiaolian, actually, I was in the meeting of EBC in Brussels, and I don't know if you have seen some presentation there. Last day, they presented by Adrian Panning a presentation, a sub-analysis of EBC main trial accordingly to definition complexity criteria. Then in that sub-study, he showed that those who are defined simple bifurcation, provisional stenting is equal to 2 stents, but in those included in complex, accordingly to definition criteria, they are doing not significantly, but the trend is 2 stents is doing better than provisional stenting.
Yeah,
this is the population of EBC main study. So I hope they will be published. I mean, these data will be published as sub-study, because this can give some, let's say, some clarity and what is the direction to go with. I think, as you said before, define your lesion, complex or sample, and then go upfront provisional or 2 stents.
Yeah, I'm very happy to hear this information. This year for EBC meeting, I refused to participate. They designed one topic for me is to debate with D.H. Smith. So my opinion was that because EBC was a failed study, so it could not provide any power with our colleague. Secondly, I think our friends are sitting here, most are Asian people, right? Sometimes to convince Western people are very difficult. Most of them do not trust our Asian results, except for except for Professor Sheiban, I mean EBC team. So the third point there, even they have the very similar finding for complex bifurcation in terms of the impact of side branch lesion length on the 1 year follow-up. But that's only subgroup analysis with very, very lower power to show the real result. But I think if they expand their sample size, definitely they will get the very, very positive and similar results with us.
Professor Chen, actually, DK crush versus DK culotte. What do you think?
Yeah, my friend Dr. Kumar, DK culotte and DK mini culotte, all are my sons. I modified a culotte from traditional culotte to DK culotte. So 1 year after that, I further modified to DK mini culotte. That's all. But my another Chinese colleague, he was a leader of another randomized study to compare DK quality with DK mini culotte stent technique. He's my real brother, But for me, very busy, so I have no time. But the terrible thing is that the sample size was very small for that study. They did not get the statistical analysis, the difference.
Well, actually, just very small. Actually, culotte technique. I mean, what was described in 1998 is completely changed today. The modern culotte is absolutely completely different from what described before, but we do not have that much data showing the modern culotte, the outcome with modern culotte as compared to other studies. So I think we should wait for more data coming from clinical studies.
Yeah, actually, can I have one more comment for culotte stent technique? Actually, from our DK quality 3 study. So the 1 year primary endpoint after culotte was around 10.7%, but it was 17.7% in EBC main trial.
Yeah,
so
but
definitely
that was not mini culotte. That was not DK culotte. I mean, so
right.
Yeah.
It's a conventional culotte.
Professor Chen, one important point which you have highlighted is that the definition trial is getting modified basically because we now know that the side branch lesion length is put as a 10 millimeter and side branch stenosis is put as a 70% above. That really becomes a complex, and then there is the place where we have to look for 2 stents. So overall, I feel that if you have a 011 or a 111 Medina classification, if the side branch lesion length remains to be less than 10, say 5 or 7, still we could manage many of the patients with a provisional stenting. That's one thing we can have.
Thanks for your question. I think it is a very, very wonderful question. During the establishment of our definition criteria, actually we perform stepwise regression analysis to identify the cutoff value of side branch lesion length, as I showed in the figure, which was another figure to show the correlation of side branch lesion length with the clinical outcome. So no difference between side branch lesion length shorter than 5 millimeters and between 5 to 9 millimeters. So there was a very, very high jumping when the side branch lesion length from 9 millimeters to 10 millimeters. Thank you.
Can we go to the next presentation?
Yes.
Okay.
Dr. Madhu will be presenting his case. Madhu.
Yeah. First of all, thanks, Prathap, for inviting me, and it's an honor to present this in front of Dr. Sheiban and Dr. Chen. So it's PCI in Octagenarian. It's a 79-year-old man. It's a hypertensive and dyslipidemic. Is presented with exertional angina for 6 months. He presented with an acute inferior wall MI and 14-11-20, and he was lysed. Hemoglobin is 12, his eGFR is 76, is not a diabetic. ECG showed T inversion and lateral leads, and echo showed RWM of inferior wall with good LV function. This is the angiogram. showed a circumflex occlusion here, OM1 90% stenosis, disease in calcium and LAD with mid-LAD and ostial LAD disease. More important part was, he had a tight lesion in the ramus, which is a large vessel. So it's like a 011, which Dr. Bahalain is talking about. So you had disease in ostial circ, ostial LAD. And RCA was, he had a borderline lesion in proximal part, but otherwise RCA was normal. So in summary, the angiogram with LAD ostial 70 with mid 80 with calcium, circumflex at an ostial 70% with a distal 100, and OM1 was a large vessel with an ostial 90% stenosis. RCA had a proximal lesion, which is borderline. So this is the syntax score. Syntax score was 27.5. So it's equipoise for angioplasty or CABT. And he's 79-year-old, and he didn't want a surgery. He had come, from a far distance, and he wanted only angioplasty. So the plan is a familiar approach, 7 French guide. The plan is to open the circumflex first and a 2 stents technique for LAD and ramus with OCT guidance for imaging. So first we did the circumflex lesion, which is wired with a filter XT wire, and it is pre-dilated with a sprinter and a Maverick balloon. It was occluded only for a month, so it is not too bad after pre-dilatation and changing the wire to a cyan black. And it is stented with a 3x33 cyans. This was post-dilated at high pressures and with a good result for the distal circ. Now the question was, he had a OM or a ramus ostial disease with ostial circumflex and ostial LAD disease as well. So the question is, how do you tackle this? So this is what I did. It wired the ramus first and pre-dilated with a tube balloon to facilitate an OCT to see what was the disease and what is the length and lesion morphology. So this is the OCT, which showed that the distal ramus was quite okay, but you had calcium as it comes closer to the ostial ramus with a calcific nodule, which is impinging into the lesion, with disease in the circumflex ostium as well. But as you come to the left main, it's large, roomy, and free of disease. So this is the morphology. You can see that the calcium coming there with a calcific nodule, which is protruding into the ramus ostium. So this is the summary of the OCT from ramus to left main. It's a fibrofatty with a calcification and an area of calcific nodule. The MLA was 0.99. The distal RVD was 2 into 3.3. And the proximal RVD in left main was 4 and going up to 5. And the length was 19 millimeter. And this is a OCT from LAD, which again showed that the distal LAD was quite large and roomy, but you had lots of calcium as you're going proximally into the LAD. But it is not circumferential, it is less than an arc, and the thickness was not too bad. So you do not need any plaque modification strategy apart from probably high pressure non-compliant balloon. You did not need a rota because it is deep calcium either way. You did not need lithotripsy. And as it is coming to the ostium of the LAD, you could see that it's quite narrow with calcium, this part. And left main, as we found again, was large and roomy. So this is the summary of OCT from LAD to left main, fibrofatty with areas of calcification. The MLA was 1.4. Distal reference was 3, and in left main was 4, and the length was 39. So we went ahead with, it's a plan for a decay crush from left main to ramus. It is pre-dilated with a 3 millimeter balloon at 20 atmospheres to ensure that the calcium is well open. and the LED was pre-dilated with a 3.5, and finally it was a 3x23 millimeter science, which is from left main to ramus, keeping a 3.5 balloon in the LED to crush the part which is in left main. It is deployed at nominal pressures, and then the balloon is pulled back and went up to high pressures to open the stent fully. And this was followed by crushing the proximal part with a 3.5 into 12 non-compliant balloon in the LAD, and a pot with a 4 millimeter balloon in left main, because the left main is large and roomy. So unless it's crushed completely, when you're trying to rewire the circumflex, it'll go in between the struts of the circumflex, which if it's not crushed completely, and that can distort the stent. So you always have to do a pot size to the left main to ensure that it's crushed fully. And crossing is through the proximal or the mid stent and not the distal, because if you go distally, you will go beyond the stent and leave a stent-free area at the carina. These are the two differences of the DK crushes compared to a provisional. So it is wiring through the non-distal strut, and this is followed by the kissing balloon with a 3.5 in LAD and 3 into 12 in ramus, and a 3.5 into 48 expedition from left main to LAD. This is post-dilated to high pressures with a 3.5 balloon at 24 atmospheres, and finally a pot with a 5 into 8 millimeter non-compliant balloon. Here you have to keep it a bit away from the carina so that the carina is not distorted. This is even more important when you're doing a tap rather than a DK crush, but again, away from the carina a little bit. So this is after the pot. The results after the pot. This is followed by, again, the second part when you rewire again to the mid or the non-distal strut, followed by a two-step crush, two-step kissing balloon. Here I use to alternate very high pressures to ensure that the stents are well open, followed by simultaneous kissing at nominal pressures of 14 to 16. So each individual balloon you go up to 20 to 24 to ensure that the stents are well open, followed by a repot with a 5 into 8 at 24 atmospheres. And this is the final result. We didn't have to do anything into the circumflex because it is flowing well. The plan was, in case there is some pinching of the circumflex, you would have to go and dilate with the balloon into the distal circ, but that was not needed in this. And this is the final result. And the OCT showed a stent which is well expanded. The overall expansion was around 80% with a MSA of 7.2. And there's a bifurcation mode which showed that the opening into the circumflex is well open, but not too much of connectors in between. And you have a widely open stent. The uncomplicated course is discharge after 3 days on aspirin and ticagrelor, asymptomatic, and follow-up at 10 months. So concluding, multivessel disease can be treated successfully with angioplasty. Planning of the procedure is important, and imaging is mandatory for morphology, for calcium management, length and dimension of the stent, expansion, and to exclude complications with the MLD max algorithm. Complex left main bifurcation is best treated with an elective two-stent strategy, and DK crush is the best long-term data and the various techniques for left main, and imaging would make the results last longer. Thank you.
Thank you. Thank you very much for this excellent case. Excellent case. And I think you have described very well DK crush and how to cross proximally after crushing the stent and how to pot the crushed stent before crossing. So I think it was really very, very good case. And as the outcome was excellent. Fantastic. Thank you.
Thank you, Dr. Sheiban.
Dr. Chen.
I think this case was done much better than what I have done. Excellent. You know, immediately after standing side branch, slightly move the stent balloon to optimize side stent. This is very, very important because the ramus taken from circumflex, So the stent size was adjusted according to the ramus diameter. It could be undersized for proximal circumflex. So this step is very important. Also, I found when you perform the kissing balloon inflation, so the two balloons overlap very short. I think this is the key to reshape the crown. So someday I need to learn DK question from your hand.
From other people, we will teach.
I think one or two points on that technique, Madhu. Excellent case. I would appreciate your case presentation. One is, the one main problem once when we do the DK crush, which happens is that the side branch osteal expansion, especially when you have calcium, is sometimes not achieved. You have shown in our OCT that 3D view the orifice part, but actually the measurement of the side branch osteal area has to be well obtained at the end of the procedure. And one of the hitches which was with that we place the side branch stent first, and then we pull back the same balloon, which is a semi-compliant balloon, and then dilate. It may not ensure the full coverage of the side branch osteum, especially as you have shown in your case, the calcium part. And that is where this guy, Francisco Lavara, has pointed out that you take another high pressure balloon of say 0.25 millimeter larger, and then separately dilate the osteum nicely, and then go for a kissing balloon inflation with that. I would like to get the opinion of Chen also, that was called as a proximal side optimization. And that is shown that it opens up the side branch osteum very well, and the recross also will be enhanced, especially when you do a crush with a core technique using a balloon size to the proximal vessel, and then you expand, and then the side branch crushing will be nicely over that, well open the side branch osteum. So crossing that will be easier, and non-distal crossing may be okay. You need not essentially go with a proximal strut crossing. I would like to get the suggestion on that. Is it really worthwhile doing that?
Yeah, personally, I also prefer to use another NC balloon to optimize side stent. My second comment is that I think this case is a typical example of using DK question for SS patient, because OCT confirmed the calcified nodule protruding into the circumflex. So I think it would be very dangerous to use provisional technique after stenting main vessel. Definitely, so the procedure will be shifted to two-stent technique. So that's the problem for ramus. And also why is the reason why high rate of a clinical worse event of the provisional with two-stent technique. Yeah, here I have one question goes for both Professor Sheiban and Dr. Kumar. So what's your comment? What's your opinion about the provisional with one stent and the provisional with two stent technique? Who goes first?
Imad goes first.
Okay. The provisional provisional one stent, I think it is a conventional provisional stenting. So I think, as you said before, as I also pointed out in my presentation, at least in 75% of cases, you can go upfront with this provisional stenting, that means one stent technique. To shift from provisional stenting to provisional two stents, I do not like that much, because I think we have also data in literature showing that when you are shifting, you will have more MACE on long-term outcome as you are shifting for two stents. Second point is that you have to use tap technique if you are shifting for two stents, or reverse culotte, or sometimes can also use reverse crush. But I think that all these strategies are leaving something protruding inside main vessel, and this is not the ideal way to do two stents technique, and I have shown also meta-analysis comparing DK crash, conventional crash, culotte, tap together, and showing that tap and crash are the worst two-stent strategy in this condition particularly. So I think that I will go for when I'll proceed like you have indicated, as also me, that you plan your procedure before, upfront two stents, go for what you are mastering, step by step, try to optimize everything you are doing. Then if it's simple bifurcation, go upfront provisional stenting.
So actually my question, my way is always like this. Any complex, I will go upfront two stent, definitely not a single stent strategy. But if it is a single stent strategy, switching over to tap, definitely the patient will come back with restenosis. So that is another problem we all challenge. But one question to Professor Chen or Dr. Sheiban, sir, actually LM bifurcation, you told side branch is 10 millimeters. Non-LM bifurcation also 10 millimeter will work out, or it should be less than that?
In non-lift main.
Yeah.
Yeah, actually, I think it applies to all bifurcation. Yes.
10 millimeters.
Yeah. And if we'll precise more, I think this applies only to clinically relevant side branch if it's not you are treating non-bifurcation lesions. That means if you have small side branches less than 2.5, short side branches, I think it is enough to keep it open. That means just to avoid total occlusion after stenting main vessel.
So earlier we were telling about 5 millimeters, now changed to 7, then 10 to 10. So in the LED diagonal also, or circumflex OM also, it applies or not? That is what is my question.
Yes, it applies. Yeah, it applies.
Yeah, just
in my opinion, I would like to hear also from Professor Chen.
Yeah, just two comments. Dr. Kumar, for non-left main bifurcation lesion, particularly for true coronary bifurcation lesion. So complex bifurcation lesion should meet a side branch incision length 10 millimeter, baseline side branch diameter stenosis, minimum 90%, but not 70%. Also, for the diagnosis of complex lesion, we also need at least two minor criteria. So for example, multiple lesion, bifurcation angle, main vessel reference diameter, something like that. So here I want to discuss with you. Should we conclude that provisional with two-stent technique is one of the complications of provisional stenting?
Yes, we can conclude that.
Yeah,
in my opinion, I mean, it's not based only on opinion. We have data coming from trials, meta-analysis showing that provisional two stents is associated with more MACE. So I think the reason is just because you are using some strategy that is not leaving something protruding in main vessel, and this will give more problems.
Dr. Sheiban, if you do the crush, the reverse crush, there would be nothing protruding into the main vessel, wouldn't it be?
Reverse crush will be protruding. The crushed segment will be still protruding in the main vessel. That means it's opposed, but not let's say below the first stent. It's inside the main vessel.
Right. Inverse crush has a high rate of stent thrombosis, very similar to classic crush without the final kissing volume inflation. Again, I want to say, the key point for rewiring of the stenting main vessel into side branch is always to rewire from distal cell, right? But to be honest, for most of the case, after stenting main vessel, it's impossible to rewire from distal cell. We have to rewire from proximal cell, right? So for provisional stenting technique after stenting main vessel, if you rewire from proximal cell, so the two-stent strategy should be provisional with T. if you really rewire from distal cell, so the two-stance technique is so-called provisional with TAP. So far, no data showing the difference between provisional with T and provisional with TAP. But also, from our DK quality 5 and definition 2 trial, in the provisional group, we got some data to show really high rate of MACE of the provisional with TAP compared with provisional with one-stent technique. Recently, we are collecting our 3-year clinical follow-up for our definition 2 trial. We try to get more information and data.
So Chen, again, in BK crush, you still, present that the recross should be through the proximal stent structure, or now we call it as non-distal. Should it be essentially proximal?
Yeah, before this meeting, I always stress we have to rewire from proximal cell. But today, I am very, very happy about the new concept by Madhu to rewire from non-distal cells. I think this is a perfect concept.
In this part, I think it has become now very popular to say non-distal recross, not essentially proximal. That's why I wanted to clarify. I recently listened to one of your presentations. You still presented it like that. The crossing should be through the proximal stent structure.
Yeah, exactly.
Actually, we tell proximal mid, sir. Mainly people tell it is mid only, not even proximal. Distal is very bad, but proximal is okay.
Yeah. So non-distal includes proximal and as well as mid, possibly.
Proximal mid, sir. You should not go to distal at all.
Right.
I always say we need to rewire from proximal cell, but it does not mean we need to rewire from crushed cell.
Sir, can we go to the last presentation, sir? Dr.
Yes,
Chirag,
we can go.
Yeah. So thank you, Dr. Kumar, for giving me this opportunity, and it's really a pleasure and privilege to be presenting at this forum. So straightway going for the case. So patient is a 57-year-old male who is diabetic, and he has undergone previously PCI with deaths to the LED for acute coronary syndrome 1.5 years back. And a Zion's 2.75 to 48 millimeter was placed from ostium of the LED. And now he is presented with new onset of angina with a strongly positive stress test. He has a normal LV ejection fraction. And this is what the angiographic picture shows. It's a left dominant system. And we can see a critical stenosis at the distal left main bifurcation. And with a proximal age restenosis of the LED stent, RCA was normal. So this is what the angiographic picture shows. So syntax score, as you can see here, was almost 22. We proceeded with IVUS study after pre-dilatation, and as we can see, the IVUS pullback from the LED had shown a 2.75 millimeter stent, which was relatively well expanded, but it was undersized at the LED ostium. If you see the size of the LED at the ostium, I think the 2.75 millimeter stent was undersized. So this is what the IVUS pullback from the LED was showing. The left main had a size of about almost 5.5 with a 36% plaque, and a proximal LCX was also roomy with minor plaque at the circumflex origin. I'm not going to the IVUS pullback in detail, but we proceeded with pre-dilating both the lesions with 3 millimeter and 3.5 millimeter balloons. And having pre-dilated the lesion, we placed a 4 into 32 millimeter stent from left main to left circumflex, and optimized further with 5.5 into 8 millimeter in the left circumflex ostium and 6 into 8 millimeter from left main in the left main at 18 atmospheric pressure. So having optimized the left main, first part in LMCA, as we can see, NC emerged with 6 into 8 millimeter at 18 atmospheric pressure. We rewired the LED, dilated the stent struts, followed by kissing balloon dilatation. And thereafter, LED was treated with regulating balloon 3.5 to 28 millimeter magic touch, followed by kissing balloon dilatation with non-compliant balloon 5.5 into 8 into circumflex and 3.5 to 28 dab in the LED. After that, final part in LMCA with 6 into 8 millimeter non-compliant balloon, and thereafter, this was the final result. If you see the IVUS derived diameters, the left main again shows a very well expanded stent and with good luminal areas. If you see at the point of confluence in the proximal LED also and in the circumflex ostium as well, all areas had been extremely well opened stent struts with good luminal areas. And this is how the end result of this procedure was, showing a small case of a young patient of 29 years old male with acute anterior wall STEMI with LV ejection fraction of 35%. And he was admitted with primary PCI, and this patient at admission was detected to have diabetes. So a young male diabetic anterior wall MI EF 35. And this is how the coronary angio had shown the picture. We can see a subtotal occlusion of the LED ostium, and we can see some plaque at the proximal LCX as well. This was the RC, again showing some minor plaques and collaterals which had already started filling up the LED. So right femoral axis JL 3.57 French was taken, and we were contemplating whether we should place the stent at ostium or one should consider crossover stent from left main to LED. So after doing plain balloon dilatation with 2 into 12 millimeter balloon, some fluid established, and thereafter after balloon dilatation we did perform IVUS study. And what we can see here is that proximal left main was relatively free of disease. Distal left main had a plaque which was as large as almost 48%. And if we see the osteoproximal LED, again, we can see a sizable plaque burden. So we adopted a strategy that probably we'll have to go crossover from left main to LED. Proximal circumflex did not have a significant plaque burden, and we thought that we will go ahead with a provisional strategy only. Ultimaster tensai 4 into 24 crossover from mid left main to LED, avoiding the ostium of the left main. And thereafter the stent was put, leaving the wire in the circumflex. And after stent deployment, proximal LED stent did look a little under deployed, optimized with non-compliant balloon 4 into 12. Thereafter port in the left main with 4.5 into 8 at 18 atmospheric pressure. And having optimized left main, after retrieval of wire, we had recrossed into the circumflex, and a kissing balloon dilatation was done with 4.5 to 8 millimeter into LED, and finally 2.75 millimeter, 2.75 to 12 millimeter in circumflex, and thereafter final port in left main with 5 to 6 millimeter at 18 atmospheric pressure. So this is what the end result was in the PA cranial view, in the aleocaudal, and this is what the result was in our aleocaudal view. So with a provisional stent strategy in a young patient diabetic, we could salvage this condition with a crossover stent from LM to LMB. And these were the final areas on IVUS, point of confluence 16 millimeter square, LED ostium 9.5, and circumflex ostium about 5.85 millimeter square. So I think for the sake of time, I will end my presentation here and would be happy to hear comments and look forward to learning. Thank you.
Thank you very much for these two very interesting cases, very well done. Actually, that also gives the opportunity to discuss about the use of drug-eluting balloon in these cases as well as, please.
Yeah.
Any comment?
So actually, I was saying that the last case, actually, the circostium was not well opened up. That is what I feel. Otherwise, the cases were very good.
In the first case, you have use the drug cotton balloon into the LED first, and then you followed it up with a kissing balloon. Am I right?
Yes.
Yeah, I only wonder, when you have treated a lesion with a kissing, with a drug cotton balloon, and then go with another balloon and then inflate it, you are not sure part of the drug is removed from that when you use another dilatation. So I think that is has to be kept in mind. And the second case is, second case, I think, even if you don't have a plaque burden in the distal left main of a 45 or 50, that angulation and that lesion being the ostium, it is always better to treat into the left main. So even if you don't have an IVUS, I would treat it with as a left main to LED crossover stenting.
Agree.
That's right. And regarding addressing the circumflex, there was some lesion there, but the flow was quite good. And the pinching also was not great. So I don't know whether that is ready to be addressed by a kissing balloon inflation in that situation.
Yeah. I agree with you. I mean, I don't hear how much was the ratio between the balloon and the circumflex. It was 1:1 in your
Yeah,
case?
the size was 275 to 3 millimeter, and that's why we had selected 275 millimeter balloon only
Okay.
in the circumflex.
Yeah, actually,
It was
I mean,
it was
yeah.
1:1.
Yeah, actually, as we have discussed before, I mean, if you have good flow, you don't have that much compromise on or pinching on side branch. Normally, you can leave it without doing anything.
Right.
If you need to open some strut, I think it is good to go with small size balloon inside branch in order to avoid dissection, in order to avoid stent deformation. Because if you are going with large balloons, then you have stent deformation, then you have to go again with more aggressive case and pot and so on.
Right.
I think, Dr. Sheiban, you mentioned about, checking with the balloon, whether it is causes,
Yes,
and then
yes.
you stop at that stage at that.
Yes, yes.
Yeah.
If it is causing very well, you leave it at that.
Yeah, yeah.
Right. Right.
That is also
Recently, from workers, I happen to see that there is a push balloon technique of, side branch type.
Yes.
Any comment on that? Anybody, Prathap, have you heard that?
No, sir. Actually, I do the same thing as Dr. Sheiban. Actually, whatever he does, actually, I follow that. So I just push the balloon and see that if it is crossed, I don't do anything, because otherwise, you may unnecessarily damage the career and create problems.
We do not have studies on that. We do not have data, but I think it works from practical point of view. It works.
Yes. Now, well, Prathap, those who are imaging, they image and try to find out what is the jailing pattern of the side branch and then address that.
Yeah.
Right.
Just one question.
Yeah.
So after studying already two left man, did you have intravascular image to see what the reason for circumflex compromised?
The first case, if I'm getting it correctly, is it for the first case?
Second case.
No, it's second case. I think.
Second case.
May I ask to repeat the question? No, circumflex was not compromised, but since there was already some plaque there and the patient was young, diabetic, we thought that at least we should leave struts toward the circumflex open. That was the only reason to go to the circumflex and open the struts. There was no otherwise reason.
Yeah. So my question is that what's your indication for ballooning circumflex after stenting main vessel?
It was to keep the stent struts open towards circumflex. I mean, just to keep the stent struts open towards the side branch, which was important. Which had some plaque, but at least we'd leave the access to that branch open in a patient who is young and diabetic. So it was only for that in the mind that we'd done it.
I think this is a very important strategy. We do have some cases after provisional with one stent crossover from right to left main. We did not perform kissing, but after 6 months to 1 year, there are many materials on these struts covering at the ostomal circumflex. So patient presented with unstable angina. So I think your procedure looks very nice.
Thank you, sir.
Actually, I just have one question to Professor Chen. If you are actually converting provisional to the double stent strategy, what will be your strategy? You have no decompress that time. So what will be your strategy?
I think the question is very challenging me. Because, for Dr. Kumar, basically for complex bifurcation, I do not use a provisional at all. But, for some simple bifurcation angiographically after stenting vessel, this circumflex also compromised very severely. So this means the importance of intravascular imaging.
Professor Chen, if you're doing a simple bifurcation, you're doing a provisional stent, you open up the side branch as we discussed in these cases. And if while opening up, you have a dissection of the side branch, how would you tackle it?
Actually, for left main, similar to the second case of stenting main vessel, I will definitely to check intravascular imaging. I was also AT. If the cerebral circumflex is compromised by cryonic shift, I will only use a small balloon to dilate the cell and to perform kissing. If it's caused by plug shift, I will use 1-to-1 balloon for cell and to kissing. But the concern, is the high rate of restenosis at the proximal circumflex. So far, many issues to be done, many issues to be answered.
So you will avoid always a professional standing in all matters, and if it's all professional, it will be only professional. No double step.
Upfront to stay.
Upfront, yeah. Actually, my personal opinion is that for complex distal left bifurcation lesion, if you only deploy one stent from either ID or circumflex to left main, you could not sleep very well at night.
So, sir, actually, Dr. Professor Sheiban, sir, we can conclude the session because 15 minutes we passed.
Okay.
And moreover,
Okay.
Chen is, the time is too much for him.
Yeah, I think
fine.
we had a fantastic webinar because we actually the time passed very quickly. That means we enjoyed what we have here. The cases were fantastic. Presentations also, I think, covered what is interesting today to many operator, particularly young operator who knows to know more and more about what is going on. And I think this was really very educational event, and I would like to thank all the participants, all the speakers, the discussing panelists, and attendees also as well. We don't see on the screen, and hope to have you all tomorrow back for the next session. Yeah, on intravascular imaging in left main PCI.
So same time, but Professor Chen 30 minutes before.
Okay. I'm so sorry.
Okay.
See you tomorrow. See you tomorrow. Thank you. See you tomorrow.
Thank you.
Thank you. Love you.
Thank you, sir. Thank you.
Thank you.